going to take a punch biopsy from this lesion here on Denise's leg. She's 74 years old. She's had a previous history of a bones disease or squamous cell carcinoma here on the shin about 10 years ago. So this now has appeared here for the last few months. It's quite faint, but it probably is another area of bones disease. It could be an actinic keratosis, so it's important to get the diagnosis correct. So we just clean the skin with a little bit of methylated spirits and then a little bit of chlorhexidine, and then dry the skin and mark it with a marker. It's very important to mark it because once you put the local anesthetic in, you may not find it because the skin will blanch and that redness will disappear. So we're going to use 1% lignocaine with adrenaline. Small pinch here, Denise. You ready? Small pinch. That's it. Well done. And then just inject nice and slowly. And just infiltrate. You okay?
Yeah.
Okay. So just going to infiltrate into the skin and a little bit under the skin. The only vital structures here would be some veins, so we obviously try and avoid those if we can. If you do hit a vein, it's not the end of the world, you can just stitch it. Stop the bleeding. So there's local anesthetic, so that's going to take about a minute or two to go numb. We just raise the skin up a little bit, which will actually protect the underlying structure, so it brings the skin up. That's a very useful technique if you're taking a punch biopsy from the face. Sometimes you put in a lot of local anesthetic to lift the lesion off away from underlying structures like blood vessels and nerves and so forth. So now we're going to take the 4mm punch biopsy from this lesion, which is about 7 or 8 millimeters in diameter. The most important thing is to avoid any underlying dangerous structures. The only one in this area would be the common perineal nerve, which runs at the head of the fibula, at the lateral aspect of the knee. If you cut that, you'd end up with a foot drop. But obviously we're miles away from that. So here, the only thing underlying here would be some veins, which shouldn't be a problem. So again, this is a 4mm punch biopsy, so slightly bigger. The 3 would be the most common. So we're just going to take a punch again. There's local anesthetic is in. It's been in for about 3 minutes, so it should be completely numb. You okay, Denise? You don't mind watching?
No.
Okay. So we just put it into the area and just rotate and go down. It's gone pretty much the whole way into the hilt. So again, if it comes out easily in the shaft of the needle, that's good. If it doesn't come out easily, sometimes it gets stayed in there. You can pick it up with a needle and just cut it with a scalpel blade, but you want a good generous cuff of fat. So there is the specimen. So it's a nice cylinder, and this is the skin, the subcutaneous tissue, and there's the fat underneath. So that's a very good representation. And so we're going to send that off on a histology in 10% formalin, and that'll come back in 2 or 3 weeks. You can put the stitch in different ways. Normally the lines of skin tension go this way on the leg, so we'll put the stitch in here. With a 3mm punch, normally 1 stitch would work, but I often put two stitches in if it's a 4 or 5mm punch. So I'm going to put 2 stitches in. These will stay in usually for about 2 weeks in the leg. So these are just 2 interrupted sutures. Okay. So it's come together nicely. And a reverse throw and a forward throw. So then just putting this into my palm, getting the scissors, using my 3rd and 1st finger, and just cut that. So it's a quick way of just not having to leave down your needle holder. So then we put just a dry dressing over this. The patient keeps the foot up for the rest of tonight. If they're on anticoagulants, we try and stop them if possible. If not, just compression will help. And the stitches will come out in 2 weeks, and the results are usually back in 2 or 3 weeks.